Lower leg? No? Okay. Well, we'll go over it. The tibia. What else do we call this bone? The shin? Yeah. So it's the second longest bone in the body, and it serves as the principal weight-bearing bone of the leg. It's shaped triangularly at the top. So up here, where it's closer to your knee, it has more of a triangle shape. And then as you go down, it ends up being more rounded and slimmer. That's why it's weaker in the lower third of it. This is the site where most fractures occur in the leg. Fibula. It's long and slender and located on the lateral aspect of the tibia. Remember lateral, medial, all those directional terms, right? On the outside? Yeah? Okay. So lateral is going to be on the outside. Your fibula lies lateral to the tibia. It connects at both the proximal and distal ends by strong anterior and posterior ligaments. The main function of the tibia is to provide attachments for muscles. Tibial and fibular malleoli. Those are what we normally think of as your ankle bones, right? The two little bony, yes, exactly. One's on the medial side, which is what? If there's a medial or a tibial and a fibular malleoli, and the tibia is medial to the fibula, show me which one that would be. Mm-hmm. The fibular? Mm-hmm. And the tibial. They extend distally so that the stability is created by the bone arrangements in the ankle joint. The bone extends further on the lateral side. Which bone is that? It's on the lateral side? The fibula, right. It's longer on that side, and it gives more stability on that side. For the anatomy, we need to review this. I'm going to go back to the picture, but just for a second, look at the lateral ligaments. Anterior talofibular, posterior talofibular, and calcaneofibular. Mr. Davis talked to you yesterday about the ligaments are named because of the bones they attach to, right? The medial ligaments, deltoids. So let's go back to the picture. We know number one is what? That this is the lateral view. The tibia, exactly. And number two is what? The fibula. Okay, so if number 7 connects the fibula to the calcaneus, what ligament would that be? Right. And what about number 3? It connects the fibula to the talus. So what would that be? Right. Because posterior means it's on the back side, right? And what about the front one that's also number 7? It's on the anterior side, and it connects the fibula to the talus on the anterior side. So what would that be called? Exactly. Geniuses, all of you. Okay, and then on the medial view, that little picture there, it says number 8. It connects the tibia to what?
They're dealing with Austin over here, an issue.
So we said that we'll go back to that slide. The medial ligaments are the deltoid, okay? It's shaped kind of like a triangle. It's really thick and fibrous. That one's harder to sprain. So I know we talked to you yesterday about how most ankle sprains are on the lateral side, right?
Hey.
Yeah.
That's too loud.
No, we're talking about in the ankle. Okay, here's a different picture. It's showing those same ligaments we talked about, but a little clearer view. Posterior talofibular, calcaneofibular, and anterior talofibular. Now, if you were to go up to an athlete, or even to yourself, you could pretty easily take your middle 3 fingers and lay them on the outside of their ankle like this, and pretty much follow the path of where those ligaments lie. So if somebody's saying that they have pain right here, you can pretty much guess what it's going to be, right? Especially if they tell you that they did it by turning their ankle this way with their foot going in. More anatomy. Okay, so we know tibia and fibula. This interosseous membrane, that green right there, that is connecting. It goes in between the tibia and the fibula. When we have high ankle sprains, a lot of times that's what's involved, as well as the anterior tibiofibular ligament. If it's the tibiofibular ligament, what two things does it attach? Right. Okay, and we have the navicular bone, the peroneus longus and brevis. Those are all muscles that go from the lower leg down into the foot. You can see the calcaneus, the lateral malleolus, and all those other ligaments. Any questions so far about the anatomy? Okay, moving on to compartments. The lower leg is divided into compartments. The anterior compartment, anterior means what? It's in the front, right? Anterior is front, posterior is back. Okay, anterior compartment contains the muscles that dorsiflex the ankle and extend the toes. It also contains the anterior tibial nerve and the tibial artery. The lateral compartment, what side's that on? Right, the outside.
Dang, why do I go that way? I don't know.
The side that the fibula is on. It contains the peroneus longus and brevis, which evert the ankle. Do we remember what inversion and eversion are? Inversion, when the foot goes in. Eversion, when it goes out. Peroneus, those are muscles. You can say peroneus or however you want to say it. I say peroneus. But those tendons go down into the foot. They cross over behind the ankle. And so they help the foot go out this way. Superficial. Do you remember what superficial means? Superficial versus deep? Superficial means it's closer to the surface. Deep means, well, it's pretty self-explanatory, right? So superficial posterior compartment. Posterior means in the back, right? So it's posterior, but it's closer to the surface. It contains the gastrocnemius and the soleus muscles. These muscles flex the ankle. Deep posterior contains the tibialis posterior, also a muscle, the flexor digitorum longus, and flexor hallucis longus muscles, which invert the ankle and the posterior tibial artery. So we're talking about muscles, arteries. They all kind of lie deep underneath that superficial posterior compartment. Any questions so far on those? No? I know it's a lot of anatomy, but compartments. All right. This is a cross section. This is like, say I'm standing right here, and they took a, I don't know, what's your weapon of choice? A saw, and they cut this way, okay? We would be looking down into that cross section. So the one at the top there, what compartment is that we just talked about? If it's at the top and we're looking down at a cross section of the leg, exactly, it would be anterior. The lateral would be here over on the right, and then the two posterior ones are in the back on the bottom. We want to prevent injuries to the lower leg and ankle. Are you listening to me on the phone? We want to prevent injuries. The Achilles tendon, pretty common site for injuries, inflammation. You know where that's at, right? Is it anterior or posterior? Posterior, exactly. We want to promote Achilles tendon stretching. You perform it with your legs straight, so the knee extended, and you're trying to stretch the upper gastrocnemius, and then you have them bend it just a little bit, so 15 to 30 degrees, stretch the lower soleus. All right, so when you tell someone to stretch their calf or their Achilles, you don't want them to just go up to a wall, legs straight, stiff as a board, count to whatever they count to, and go on their way, right? We want them to do some of it with a straight leg, some of it with a bent leg, so they're getting both of those muscles. Okay, the gastroc and the soleus are both in the calf, but one crosses the knee and one doesn't. So you're going to have to bend the knee to isolate them. Does this make sense? As far as strengthening, you want to use toe raises in full range of motion. So maybe having them get up on a step so that they can go down as far as possible and then up as far as possible to get that full range. Use inversion, eversion, dorsiflexion, and plantar flexion. Do you remember what those are? Okay, inversion we said was what? When the foot goes in. Eversion is when the foot does what? Goes out. Dorsiflexion. Don't remember? Okay. On a shark, the dorsal fin is where? On their back, right? So if your foot were a back, or were a shark, where would you picture the dorsal fin? On the top, right? Okay. So if we're dorsiflexion, we're flexing towards the dorsal side. So you'd be bringing the toes up. Does this make sense? Mm-hmm. Plantar flexion, the plantar surface of the foot is the bottom. So if we're performing flexion in that direction, it's going where? Down. Below. You plant below. Also, has anybody heard of plantar warts? Yeah. Nasty little things that end up on the bottom of your foot? Mm-hmm. All right, test for the lower leg. Percussion and compression. All right, so when a kid comes in and says that they're having pain in their lower leg, whether it's from something acute, like it just happened, you know, they fell down the stairs, or whether it's something they say has been getting worse over time, one of the first things I want to do is rule out a fracture. Okay, so with percussion and compression tests, we're basically going to take their leg. Here, Paige, give me your leg. We're going to take their leg, and for percussion, we can just tap. If we think it's a fibula, we're going to go on the fibular side, which is what, on the outside, the lateral side. If they say that they're hurting halfway down their lower leg on the lateral side, then I'm going to start a little bit further away from it and tap and see if they experience any pain at the site. You can also do it the other direction. You don't want to go straight to where they say it hurts and go tap, tap, tap. Obviously, that's going to hurt. That's not what you're looking for. You're looking for it to send vibrations down the bone. Compression. Compression is when you're going to take both those bones, tibia and the fibula, and you're going to gently squeeze them together. All right? If there's any kind of fracture down there in the bone, squeezing the two of them together is going to move that site, and it's going to hurt. They're not going to like it. It's not going to be one of those, yeah, that kind of bothers me. It's going to be one of those, holy crap, get off me, you know? It should be obvious. So make sure also when you're squeezing, like I said, if you're squeezing right where it hurts, it could be bruised. So you want to not only do it right where it hurts, but also start above it and work your way down. And then you can start below it and work your way up. You can also tap the bottom of the heel. I almost forgot to mention that one. So like when I had her foot up like this, all I was doing, kind of supporting her foot here and taking the palm of my hand and tapping her heel. All right? So it's sending force up through her leg. That should also cause pain if there's a fracture. A Thompson test. This is a special test that we use for the lower leg. You squeeze the calf muscle while the leg is extended, and the foot hangs over the edge of the table. So I would have the person lay on their stomach with their foot kind of hanging off the end, and I would squeeze their calf. A positive test is one in which when you squeeze the calf, the heel doesn't move. All right, so if somebody's laying here on their stomach and their legs like this and their foot's hanging off the table and I squeeze their calf, if they have a healthy Achilles tendon, their foot should move when I squeeze it. If it doesn't move, we have a problem. If it doesn't move the heel or pull upward, then you have an injury and you want to compare it to the other leg. Okay, so maybe it doesn't move a lot, but maybe their other leg doesn't either. All right, so you have to compare both sides. But if there's a noticeable difference from one side to the other, they probably do have a lower leg injury. Perfect. All right, see what he's doing? He's got the patient laying on his stomach, foot hanging off, and he's applying that squeeze right around the calf muscles. Any questions so far? Trying not to blow through this and go too fast. We haven't had to learn anything in a while, so. All right. Compression test, I just talked about that a minute ago, where you compress the tibia and the fibula together to check for fractures. That's where I said you're not going to start right on the spot where it hurts. You're going to work your way from above it or below it towards the side. Anterior drawer. Anterior is, again, what direction? To the front, right? You're going to use this test to determine the extent of injury to the anterior talofibular ligament, primarily. So, I mean, that's the one you're looking for the most. But you may also have a positive test if there's damage to the other ligaments on the lateral side. So the athlete's going to sit on the edge of the table, and I'm going to hold on, well, not just me, you if you're doing the test. You're going to hold on to the tibia with one hand and the calcaneus, so the bottom of their heel, with the other. And you're going to push the tibia back and pull the calcaneus forward. So it's going to be a sliding motion. There should be a picture here. See, he's supporting the heel and the tibia, one with each hand, and he's just going to pull. So you're going to pull the heel and push the tibia. It's a positive test if there's a clunk, sound, or feel. It should be a pretty gentle little tug, and then it should stop, right? If the ligament's doing what it's supposed to do, it's not going to let you clunk it all the way forward. It's not a very long ligament. So if you pull and it stops, again, you might want to check the other side because everybody's different. Check the one that's not hurting them and see how far it goes. But if you hear or see it clunk or feel it, then they've probably damaged those ligaments, and it's allowing the foot to move much further than it needs to. Any questions on that test? All right, the talar tilt. This is another one for the ankle. The talus is a bone where? In the foot or in the leg? The foot, yes. You're going to use this test to determine how bad an inversion or eversion injury is. So you're going to have the foot. Let's just see the picture first. There's not one. I lied. Okay. So you're going to have the foot positioned at 90 degrees, so similar position to what that last test was, the anterior drawer. You're going to have them sitting pretty much the same way. You want to have the lower leg stabilized, and you want to invert the calcaneus. If there's more motion than there should be at the talus, it indicates an injury. So again, you might want to compare the other side. You're taking the foot, and you're holding the leg, and you're actually moving the foot in to see if it goes further than it should. Check the other side, it stops here, great. Check the injured side, it goes all the way over, where you feel a clunk, or it causes them lots of pain. then they've probably injured those ligaments. And you can do it both inversion and eversion. Okay, an inversion ankle sprain. This is the most common sprain you're going to see. Inversion is when the foot moves what direction? Inward. Okay, so there's going to be several grades to this. A grade 1, they come in, they say, yeah, it kind of hurts. I turned my ankle, my foot went in. Maybe they have a little bit of a limp, but they can still walk. It hurts right where the ligament is, and there may be some swelling. But when you do those tests, the talar tilt and the anterior drawer, they're not going to be positive. You're not going to feel a clunk, and it's not going to move a whole bunch, right? I mean, I guess unless they really messed it up a long time ago, but that's a whole other thing. Okay, you'll get into asking kids when they come in, have you ever hurt this ankle before? But for our purposes right now, we'll just assume that those tests should be negative, okay, if it's a grade 1. To treat that, RICE. We remember what RICE stands for? Rest, ice. What's the C? Compression and elevation. Good job. All right, so we can use a horseshoe to control hemorrhage, limit the amount of swelling that actually gets down there in the ankle joint. Have you ever seen us take the foam and cut it into a horseshoe and put it right around the malleolus? So the malleolus sits in the bottom part of the U. All right, and then we wrap it on. And that kind of helps keep it from getting down in that joint. Because the longer the swelling's down in the joint, the longer they're out, right? It decreases their range of motion and it usually causes more pain. So we want to try and get that off. Usually for a day or two, we'll tell them to stay off of it or to be on it minimally. And we can tape it and brace it, and in a couple of days they should be fine. All right, so that's grade 1. Grade 2. They usually complain that they've either heard or felt a pop or a snap. Okay. They have moderate pain, so maybe it's a little bit more than a grade 1, and moderate disability. So weight bearing is going to be difficult. Instead of having just a little bit of a limp, they may say, oh, it really hurts when I step on it. I can't step on it. They're going to have tenderness and edema, which is swelling, right, with the blood in the joint. They may have a positive talar tilt and a positive anterior drawer. So we talked about grade 1, those tests are going to be negative, right? Grade 2, they might move a little bit. You won't feel it completely, separate itself from the joint. It's not totally torn, but there's enough of a tear in there that those tests might be positive. Again, it's going to be important to compare the injured side to the uninjured leg. With this one, RICE again, crutches 5 to 10 days. You'll work your way up to full weight bearing. That's that FWB, full weight bearing. So the first few days, they may not be able to put any weight on it at all. All right, you're going to teach them how to use the crutches and swing through. A couple days later, you're going to have them try and maybe put their toe down when they crutch and see if they can tolerate that. The sooner we can get them off crutches and walking without pain, the better. All right, so you're going to work your way up to full weight bearing. You're going to do some range of motion exercises. You know how we tell them to do their ABCs or to do the ankle pumps, all directions? They can get full range of motion. Increase proprioception. So when we talk about, like, I have them get on these balance mats and work on single leg balance. That would help. Also strengthening, they can use bands, they can do heel raises. And we're going to keep doing all those RICE steps to decrease swelling. Are we good on grade 2? Grade 3. This is the bad mamma jamma. Severe pain at the region of the lateral malleolus. So weight bearing is not possible. It's not just, ow, it really hurts when I step down on it. It's carry me off the field, or I'm going to limp like crazy and collapse and be all dramatic. I mean, you might see that. Discoloration. So the bruising is going to be that lovely purpley blue, eventually green all the colors of the rainbow. The talar tilt and the anterior drawer, those will be positive if it's a grade 3. Not just maybe positive, not just a little bit positive. You'll feel a clump. Rice, again, you want to protect it. Non-weight bearing, so crutches again. Grade 2, we said 5 to 10 days. Grade 3, you may need to progress them a little slower than 5 to 10 days. It just depends on how quickly they're progressing and what their tolerance is. Isometric exercises. Remember the difference between isometric, isotonic, and isokinetic exercises? Okay, so for isometric, we might have them go up to the wall or the table and push their foot out against it, but they're not actually moving the joint, okay? They're working on strengthening that muscle without having to move the joint through the range of motion. You'll have them increase range of motion slowly, balance exercises. These kids are going to be more prone to sprain their ankles again in the future. So you might want to get them on a preventative type program, working in the proprioception, like the balance, the strengthening exercises regularly, maybe a couple of times a week. You'll want them probably to get taped for quite a while after they've gone back. But actually, that class I just took, the studies do show that these kids, most of the time, will get another ankle sprain. So it is our job as athletic trainers to prevent that from happening. First one already happened, can't do anything about it, but we can help them prevent the next. All right, so see, this is the mechanism. The foot goes in, fibula goes out. Ouch. Kind of funny when you see somebody do it in high heels, but otherwise not so funny. All right, so this is why we tape ankles. Everybody's pretty good with their ankle taping by now, right? We've done all the testing. Whoa, too many at once. How much time do we have left? Okay, we can stop there. We got through the sprains. Does anybody have any questions about grades 1 through 3 or the anatomy? No? Okay. Tomorrow.